I had a meeting with the surgeon to show the results. We had a high number of good results with exotropia, but not so good with the esotropia. And I was just trying to get to the bottom of it. And the surgeon told me she was actually always operating cautiously. So when she had the esotropia, she was trying to undercorrect them, but she wasn't achieving the result she actually wanted to. It always was less. So instead of her getting, say for example, somebody at about 10 diopters, undercorrecting them to 10 diopters, she was actually getting 20 diopters, and that was the reason for the high borderline. And with the exotropia, she was actually trying to overcorrect them and put them at ESO of approximately, say, 10 diopters. But she wasn't actually achieving that maximum amount she desired. And what happened were they were falling into, say, 0. So for example, maybe she was wanting to undercorrect them to 15 diopters, which would normally give a borderline result, but she didn't achieve that with the exotropias, and they were falling to absolute straight head position, or maybe 2 diopters ESO. And that was the reason for a high percentage of good result with the exotropia.
All these patients were done by just the one surgeon?
Yes, yeah, it was the same surgeon. Now I'm going to go a little bit and talk about the amount of surgery you would do. So when you actually, so for example, if you have this, so you've got somebody who's got an esotropia, the eye's turning in. What you want to do, and if they are the same angle for near and distance, what you want to do is a recess and resect. So recess is weakening the muscle, and you would weaken that side, and resect is strengthening the muscle, so you strengthen that side. Cut the muscle, make it shorter, and here, cut the muscle and reinsert it to a different position. The type of...
So can I...
Yeah. Now the amount you cut and the amount of effect you get varies slightly. So if you strengthen muscle, for every 1 millimeter you cut, you get 4 diopters of effect. And weakening, for every millimeter, you get 3 diopters of effect. So if you, ideally, you want to put a patient into an isotropic position by about 10 diopters. So if you have somebody with 40 diopters squint, what you want to do is, and in this case, this is slightly different. This is a patient who has a squint only for near, not for distance. For someone who has a squint for near, not for distance, you want to do slightly different surgery. You do bimedial recession, so you weaken. So with the weakening, you have 1 to 3 relationship. For every millimeter, you get 3 diopters effect. And I've put that there. So if a surgeon wanted to cut 5 millimeters of muscle, they should expect a 15 diopters effect with that relationship. So 5, 3, 15, and you do the same with the other eye, you get 30 diopters effect. So if you want to undercorrect the patient, then ideally you're looking for a patient who's got 40 diopter squint, and you get 30 diopter effect. But if you are aiming to get them absolutely straight, then you're looking for a 30 diopter patient, and you get the 30 diopter effect there. I've got example number 2. So this is a patient who would be esotropia for near and distance. In that case, you don't do a bimedial. You don't operate on one muscle on both eyes. You actually operate on 2 muscles on each eye. The relationship is slightly different in that one, so there's 1 to 4 relationship. And again, if you want to undercorrect a patient by 10 diopters, so you're looking for a 45 diopter patient, and you get a 35 diopters effect. But if you wanted to get them absolutely straight, then you look for a 35 diopter patient. Now, that's a table. The consultant I was working with, she operated on 8 millimeter, 9, 10, 11, and 12. And I've shown the diopter effect that you would get with a recess resect. On the right side, you can see with a 10 millimeter, you get 35 diopters. With the 12, 43. I'm going to concentrate on the 10 and 12 because she operated on many more patients on 10 millimeters and 12 millimeters. So,
can you explain that again? I'm sorry, I didn't quite understand what you're saying.
Oh, okay. That shows the amount of muscle that was cut, 8 millimeters.
There's recessions there. So this is for recession resections, and that's just the amount cut for the
that's
resection
correct,
part.
Yeah. So she did 4 millimeter recession.
I think obviously the title of that,
Oh, so it's not a cut, it's one's recessed and one's
No,
resected.
one's
total
recessed
muscle
and one-
affected.
Yeah.
Oh, right.
So that's the total muscle
Ah.
cut. Then I've broken
it's
it
not-
down into recess, so you get 4, 3, 12, 4, 4, 16,
Right.
so you get 28 diopters there. So on the left-hand side, it actually shows the total amount in millimeters the muscle was cut.
So you
In
combine
the middle
recession
two
and
actually, shows what exactly, because of the relationship difference between recess and reset.
Thank you.
That graph shows the number of patients who are operated on. The one I've highlighted blue are the number of patients. And I'm just going to go over that in slight detail. So the 6 patients there who had 10 millimeter surgery, you would expect a 35 diopter effect. You can see the 2 bars on the right hand side. They were as we would expect. But number 1 on the axis here, you can see there was absolutely no effect in surgery. So she did a 10 millimeter recess resect, but we actually had no change in the patient. The patient went in with a 40 or 45 diopter squint, and he or she came out with that as well. Now, that table is actually all those patients who had that same amount of surgery, the 10 millimeter. But that table was to find out what was the reason for any of the patients who had poor results. So the very first one I mentioned that didn't have any change at all is the first row. That was actually constant esotropia, but the surgeon did a bimedial recession on that patient instead of recess resect. The age was 1 year old, and the patient had specific learning difficulty. Normally, well, when I spoke to the consultant, she said with specific learning difficulty, it's difficult because they have variable angles, and variable angles, and she said their brain is geared in a different way.
There's no evidence that people with specific learning disability, i.e. dyslexia, eyes that are any different to anyone else. So I think it's wrong to say that the result is attributable to the specific learning
Difficulty.
that may be
And
attributable.
no variable angles.